mild pulmonary hypoplasia as part of the sequence also. After fixation with formalin, just to show you better the posterior urethral valve. So this is the verumontanum, normal structure, and the valves are always around the verumontanum. And this is one of the most striking cases I've seen. Very obvious, everyone can very easily see these thick valves. So the next case I'll show you is a baby who, this again is the open abdomen. So, well, I'll show you the external after, some of the external features. Let's start with the root cause of everything. So here is liver and stomach. We've removed the bowel. This is a very small bladder, so a hypoplastic bladder, and this is not a ureter. This is actually an umbilical artery. So we should be seeing ureters here and here, but very difficult to appreciate. And kidney not definitively identified. So if we come to the right, we've now moved in even closer. And you can see this is the umbilical artery again. And these are large left and right saucer-like adrenal glands. They should have been curved over kidneys, which are not there. I'm not sure if this is it here. We had a nubbin or two of tissue, but on histology, no kidney was identified. Okay, so this is a case of, well, along with this were features of oligohydramnios sequence. Very striking facial features. I opted not to share those, but the beak nose, retromicrognathia, low-set posteriorly rotated ears, and the feet show marked talipes equinovarus deformity. And along with that oligohydramnios sequence is usually pulmonary hypoplasia. So on the right is the open thorax. This is one side of the rib cage where we opened it. This is the other. So one pleural cavity, usually the lungs fill up a fair amount of the pleural cavity, but these are the small lungs, lots of empty space. Here is the other one, lots of empty space. Okay, and this baby had significant pulmonary hypoplasia. So this was a case of Potter's syndrome, renal agenesis with oligohydramnios sequence. I think this is the last case I'm going to show. So this baby in the antenatal period was noted to have a large cystic mass in the abdomen, and after delivery did not do well and died within I think 24 hours of birth. So on the left, I've just focused on the baby's abdomen. We could see that it's markedly distended. The veins are also markedly distended. And of note, because it's important for what I'm going to show you next, the external genitalia were normal female, and the anus was patent. So unfortunately, we, in my department, I think it happened when we had some electrical and IT issues, and some of the photos were lost. So I like to show things in situ. It's you can appreciate it much better, but those are not available for me to share with you. So I'll just show you again, starting on the left. This is the resected uterus with cervix and vagina. So this is the uterus, the cervix, and this massive thing here is the vagina. The vagina was blind-ended. There was no opening onto the perineum for the vagina. And the vagina collected fluid and became a massively distended cystic lesion that compressed the large bowel and small bowel and actually gave this the impression that there was an associated gut malformation, but we were not able to find any fistulas between the colon and the this genitourinary structure. The bladder was no fistulas from the bladder either, no atretic segments in the bowel, and no markedly, well, the only markedly dilated segment was proximal to where the cystic mass was compressing. So we still thought it was consistent with a cloacal defect, but we were unable to prove any anorectal malformation in association with this. The baby did also have 1 or 2 cardiac defects, including a secundum type ASD. Okay, so those are the major malformations for last year. For the antepartum deaths, we had 13 babies in whom we did autopsy, and I'll talk more about them in the next presentation. But they included babies who had, for instance, where the placenta had, for instance, a chorangiomatosis, 1 or 2 with severe chorioamnionitis and velitis, fetal vascular malperfusion. Okay, so things that are known to cause antepartum death. For intrapartum asphyxia, anoxia, and trauma, there were no cases of trauma, but we had babies with history, either history and or features consistent with intrapartum asphyxia. So this category in Wigglesworth, they define it as babies who have a problem during labor that resulted in unsuccessful delivery and fresh stillbirth, or had low APGARs and died subsequently to that. That's it in brief. So these are the 4 infants. Well, it's 5. So in 2 babies, there was a large retroplacental hematoma with fresh stillbirth. It was actually difficult to categorize these babies because they were premature infants. Well, they were preterm and under 30 weeks. So if there were no abnormalities, I would not classify them here because their death could be related to prematurity. But with a large hematoma, I opted to put them here. We could have further discussion on that. There was 1 baby where mom had prolonged labor with maternal exhaustion and required vacuum extraction. And then on the nursery, the baby had low APGARs and had features of hypoxic ischemic encephalopathy on the nursery and died within 48 hours of life. At autopsy, we found a very large cephalohematoma and skull suture diastasis involving the sagittal and coronal sutures. There were some changes consistent with hypoxia, and then in association with the mechanical ventilation that the baby required, we found acute interstitial pulmonary emphysema in the lobe of 1 lung. So it wasn't diffuse. There was 1 baby with fresh stillbirth, didn't have morphologic features diagnostic of asphyxia, but it doesn't mean there's no asphyxia. And with no other findings, we opted to leave this baby in this category. And there was 1 baby with perinatal hypoxia, changes consistent with hypoxia. This baby, interestingly, had brain changes on neuropath examination that were suggestive of ischemia that happened before birth. Baby also had Enterobacter bacteremia, and based on the clinical findings, this was thought to be genuine infection. So he died within 48 hours of birth. We only did autopsy on 4 babies with prematurity. I'll just show you one and I think give a summary of what else we found. So this baby had all of the major complications, well, not all of the more common and major complications, unfortunately. So he had hyaline membrane disease, which was associated or complicated by pulmonary hemorrhage. There was, on examination of the brain, there was intraventricular hemorrhage secondary to germinal matrix hemorrhage. On examination of the gut, which is what I'm showing you here. So this is an open photo of the abdomen. Liver up here, gallbladder, stomach, transverse colon, and this is the small bowel. So on the right of the photo is pale but healthy small bowel. But on the left, you can see this bowel that is hyperemic and even dusky in places, dilated, and on histology showed features of ischemia. So overall was consistent with necrotizing enterocolitis. The other babies showed a mixture of findings, including hyaline membrane disease, pneumonia in one. 2 other babies also had germinal matrix hemorrhage with intraventricular hemorrhage, and 1 baby had sepsis. So otherwise, outside of the premature period, we had 4 cases that I grouped as under infection. So you need some proof of infection. You need good proof to put a baby here. The first 3 are pretty straightforward. We had 2 with E. coli and 1 with S. maltophilia. And then there was another baby I chose to include because this baby had severe necrotizing chorioamnionitis. And I think this was a baby who, in association, had some acute velitis as well. So one of the babies with E. coli had severe necrotizing pneumonia. I think I'm going to show you that baby. Yes, so term baby, E. coli sepsis, and along with that was severe necrotizing pneumonia. One of the worst cases I've seen in a long time. A lot of the lung was lost and a lot of hemorrhage was there in association with that. So I'm just showing you the external surface because the cut surface doesn't illustrate it well. So if you look at the left lung, it's more obvious with the light we have for this presentation. But if you look in this region, you can see some pale patches surrounded by darker patches. Here is a larger dark patches. So the pale ones are areas where there is necrosis, and the dark ones are hemorrhagic areas. I think we mentioned the baby with macrosomia and cardiac findings earlier. So at autopsy, this baby was, by the time baby came to autopsy, I think edema secondary to all the complications resulted in a weight that had just crossed 6,000 grams. The heart was markedly enlarged, but there were no structural abnormalities. In other words, no valvular disease, no hypoplasia of chambers, anything like that. So also no endocardial fibroelastosis. So something like hypertrophic cardiomyopathy is high on the list for the cause of the cardiomegaly. I think we're still working on the heart for this baby, and a final is not out on this one as yet. So overall, if we look at all the Wigglesworth categories, I've gone through categories 1 to 6 with you. We had no babies who fell into 7 or 8. And we had 2 babies that ended up in the unclassifiable category, really because we were unhappy that we had enough information to clearly and comfortably put them in one of the categories above. So with that, the first column has the actual numbers, and the second column with the denominator being all perinatal deaths in which there was an autopsy. So that amounted to 33 babies. And the most common thing was unexplained, well, the antepartum death category. And followed by, we had 5 cases that we put in the intrapartum asphyxia category. So that's the next highest. Keep 2 things in mind. Of those 5 babies, 2 were somewhat difficult to classify because they were premature infants under 30 weeks. But there was a large retroplacental hematoma on the placenta of both of these babies. So they're in that category, but how you classify them can be up for debate. And also keep in mind that a lot of premature infants did not have an autopsy. So if we included them, this rate would actually be much higher. So that's it for perinatal deaths. So just to show you in brief what happened with the autopsies on late neonatal deaths, we had 5 babies that we did autopsy on. One baby was 17 days. He had hypoxic ischemic encephalopathy. Another 13-day-old baby was premature with bronchopulmonary dysplasia and intraventricular hemorrhage. A third baby at 8 days had hyaline membrane disease and intraventricular hemorrhage. One baby at 15 days had sepsis with hyaline membrane disease at term. That's the old-fashioned term. We know, of course, that this disease is almost identical to diffuse alveolar damage that we see in acute respiratory distress syndrome in older children and adults. So we could alternatively use that term. And one baby had pneumonia with pulmonary hemorrhage in one lung. Okay, so back to perinatal, and to summarize the perinatal autopsy rates. So the stillbirth autopsy rate was 73%, pretty close to the 75% that we aim for. The early neonatal death rate was 37%. And we see this every year. We know that in the small prems, it can be difficult to get permission from parents to have an autopsy done. And overall, as a result, the overall perinatal autopsy rate is 55%. According to our findings at autopsy and by applying them to extended Wigglesworth, the most common thing we saw was antepartum death, followed by intrapartum asphyxia. But of course, as I said, immaturity would have been much higher on the list if we were trying to classify using all parameters available. Okay, that's it. Thank you for your attention.
Thank you so much for your presentation, Dr. Bishop. We will now proceed to our question and answer section. I see that in the question and answer, we have a few questions that were already answered. And so far, we have one from Jeanette Farr, and I believe this may be to Dr. Fendo. She asks, what would you attribute the low numbers of referrals to since COVID? So if Dr. Fendo can respond, you can mute your mic.
Hi, good morning. I would actually like a little bit more clarification on this question, the low number of referrals, meaning with regards to what specifically?
If Jeanette Farr can just clarify her question. In the meantime, we can move on to Jean Rose. Jean Rose is asking, is there any information on the factors contributing to the number of babies with APGARs below 5 at 5 minutes? There were 28 with APGARs of 0 at 5 minutes. I will put this question to either Dr. Fenda or Dr. Craig.
Okay, good morning. So for those babies specifically, I may not be able to say directly what contributing factors there were, but just to bear in mind for low APGARs, there are several factors such as overall a difficult birth, prematurity, the maternal age, the gender of these babies. But we perhaps have to look more in detail as to which one of these factors could contribute to these babies that had the low APGARs.
Thank you very much, Dr. Craig. Dr. Samantha Walker is asking, there seems to be a difference in the number of early neonatal deaths documented by the PEDS team and the pathology team. Any reason why? I think I can put this to Dr. Bishop. I think she mentioned it at the end. If you could clarify, Dr. Bishop.
Sure, I think Dr. Craig was typing an answer, Ro Craig. There are a couple of things that can result in differences because the first thing is we are collecting death data only. And on the nursery, you are collecting a mixture of birth and death. So we sometimes have babies that cross over. They're born in 1 month, they die in another month. When you get to like the end of the year, you can have little differences there between the data. Also, there are people who come into our emergency room and deliver there, occasionally on ward 12. So you can have little differences because of those things.
Thank you for that, Dr. Bishop. I see that there are no more questions. So I will hand over now to Dr. Garbutt. Thank you so much for your attention in this session, and we'll move on to session 2. Have a great morning.
Good morning, everyone. Thank you to Dr. Fender, Dr. Moya Ro Craig, and Dr. Bishop for their presentation so far. Interesting, and as you see, session 3 will allow for the critique of the statistics. However, we have a slight mental shift as we move over to our guest speakers this morning. Today, I'm here to introduce you to Dr. Shanaz Duara. She hails from India, where she completed both her pre-medical and medical degree before her licensure in the US of A. She's a professor of pediatrics, board certified in neonatal and perinatal medicine at the University of Miami School of Medicine. She has held posts at the University of Maryland School of Medicine as an assistant professor of pediatrics, and then as a director of the Neonatal Pulmonary Function Lab before she moved to the University of Miami. Her areas of publications are numerous and they're broad and inclusive of many, many topics that I could not, but I've chosen a few to share with you. Fetal circulation, morbidity and mortality in very low birth weight infants, ventilation in preterm infants with apnea, upper airway mechanics and muscle activity, comparisons of cardiac output using different methods, and changes in oxygen consumption in preterm infants. So she comes to us well qualified and to share with us the experiences of neonates born to COVID positive mothers today. It's my pleasure to introduce to you Dr. Shanaz Duara.
Morning. It is a pleasure to be with you this morning and to discuss a topic that is of great interest to all of us, which is COVID-19 infection in mothers and what it does to the neonate. The pandemic. Coronavirus disease is an outbreak that began at the end of 2019, which is why it is called COVID-19. It's caused by a single-stranded RNA virus, probably originating from bats and/or pangolins. The first local outbreak was reported in Wuhan, China, and subsequently spread rapidly around the world within 3 months. To date, over 400 million cases have been reported worldwide. The incubation period is usually 3 to 5 days, although it can be delayed for as long as 2 weeks, and many cases are asymptomatic. SARS-CoV-2 is a novel coronavirus currently responsible for the global pandemic. 4 other common coronaviruses are considered in the etiology of the common cold, whereas 2 newer coronaviruses, SARS and MERS, were recently implicated in causing severe disease, but in limited regions of the world. While the novel coronavirus primarily targets the respiratory and nervous systems, it has been reported to affect practically every major organ system in the body and every age group. It is primarily transmitted through respiratory spread, has infected over 400 million people worldwide, and resulted in at least 5 million deaths. The structure of the SARS-CoV-2 virus, which is the virus responsible for COVID-19. This is the familiar picture we all know of the virus with the double-walled envelope, the single-stranded RNA within the virus, the cytosol, a nucleocapsid, and then outside this envelope membrane are the spike proteins, membrane proteins, and hemagglutinin esterase dimers, all necessary for binding and cleavage of the envelope membrane. Now, the virus itself needs to attach to receptors for it to enter cells. And what has been found is that the SARS-CoV-2 virus, like the SARS virus, use the ACE2 receptors, which are normally part of the renin-angiotensin pathway, to enter cells. So in this schema, I show you the renin-angiotensin system where angiotensin is converted to Ang1 and then Ang2, and has ACE and ACE2 enzymes either promoting the conversion of Ang1 to Ang2 and then going down the left side of the screen where you have binding to the receptors that Ang2 binds to, and the result of that is vasoconstriction, cell proliferation, hypertrophy, and fibrosis, all of which can lead to diseases. On the other hand, if the pathway goes more towards the right, where ACE2 is promoted, you have the production of Ang1-9, Ang1-7, and a blockade of Ang2 production, and that either increases ACE2 levels by the blockade of Ang1 to Ang2, or you might have gene therapy that increases ACE2 receptors, and all of these end up going down the right side towards the green side of the screen, which is the protective side of the screen, where there is vasodilatation, an antioxidant effect, an antifibrotic effect, an antihypertrophic effect. And in normal people, there is a balance between the left and the right sides. So therefore, the SARS-CoV-2 virus is attracted to those cells that have plentiful ACE2 receptors. And those are usually mostly in the lung, they are in the endothelium, they are in the heart, they are in the GI tract. And within the lung itself, the type 2 pneumocytes have them plentifully, but there are several other cells of the lung, including the vascular structures of the lung, that have ACE2 receptors plentifully. And that is why the virus seems to be attracted to the respiratory tract. Now, the mechanism for binding ACE2 receptors is a little complicated, but I thought I would go over it just to give you an idea of what all needs to happen for a cell to be a good host cell for binding of the SARS-CoV-2 virus. So the spike protein, or the S protein, is a surface glycoprotein in the coronaviruses, and that mediates attachment and entry into target cells. This is made up of two subunits, S1 and S2. And the S1 subunit has a receptor binding domain. The S2 contains a fusion peptide, which is necessary so that at the end of the cleavage, S1 binds to the membrane receptor, and the FP portion, which is the fusion peptide portion of S2, inserts itself into the cell membrane to promote fusion with the viral membrane, and that requires proteolytic cleavage, so that you need to have not only the S1 and the S2, but you also need to have a proteolytic enzyme that causes this cleavage and allows the binding to occur. So in that sense, when you go to this schema, you will see that here you have a cell membrane that not only has these green U-shaped structures, which are the ACE2 receptors, but it also has these red structures, which are the TMPRSS2 or serine proteases, both of which are necessary for the SARS-CoV-2 coronavirus to enter the cell. So here you see free-floating coronavirus. Here you see a coronavirus that comes towards the ACE receptor. There's cleavage of the S protein to S1 and S2. S1 binds to the green side, S2 binds to the red side, and between the two of them, they promote endocytosis. And in that way, the virus enters the cell. Once it enters the cell, the cytosol has acidification of the endosome. The cell wall breaks open, and the single-stranded RNA viral particle is released, the nuclear protein, and it immediately goes to the endoplasmic reticulum, where it begins to replicate itself. So new virions are produced and released. There are other changes that take place at the same time, which is that the ACE2 receptor numbers would be reduced on the cell surface unless there was a mechanism for recycling it. So all of this takes place very well on respiratory cells, and that is why that is a main portal of entry for the SARS-CoV-2 virus. Now, how does SARS-CoV-2 affect the pregnant woman? The susceptibility question comes up. Are pregnant women more susceptible to SARS-CoV-2 infection? I hope to answer that in the next few slides. And the severity question comes up. Do pregnant women get more severe disease or have a higher mortality if infected with SARS-CoV-2? Now here I show you data from the CDC, which shows very clearly that when women are pregnant and get sick with COVID-19, their outcomes are much worse than those of non-pregnant women of comparable morbidities and age. And the adjusted risk ratios for ICU admission is 3-fold, for invasive ventilation is 2.9-fold, for ECMO is 2.4-fold, and for death is 1.7. And this is a very recent publication in the American Journal of OBGYN, January of 2022. Now, there are maternal comorbidities that impact disease severity in mother, just as it does in other people who get COVID infection. an older maternal age, pre-existing medical conditions like hypertension, pre-gestational or gestational diabetes, higher BMI, COPD, lower income, higher density, particularly if it's urban living, residents who have a high incidence in terms of families or neighborhoods, or live in areas that have low vaccination rates. And even if they can avoid all of these risks, many pregnant women are exposed to workplace exposure if they happen to work in an environment where they are not able to do distance work or remote work, but are closely by other people who may or may not have taken the right precautions. What about the indirect effect of SARS-CoV-2 on pregnant women? There is an increased incidence of preeclampsia once a woman is infected. Some have persistent symptoms detectable 8 weeks or longer after symptom onset, and that is in up to 25% of pregnant women. Reports of increased maternal depression, and then reduced resource availability, resource diversion, stressed healthcare systems associated with increased stillbirth and increased maternal mortality rates, increased rate of fractured ectopics, and fewer in-hospital births. So some of these are direct and some of these are indirect impacts on the pregnant woman. The two adverse fetal outcomes that are up for discussion are preterm birth and stillbirth. Now, SARS-CoV-2 infects the mother, but then there is a placenta and there is a fetus. If it is to get to the baby, it can go in one of three routes. It can go transplacentally, it can be intrapartum transfer, or it can be postpartum transfer. Transplacental transfer is vertical transmission, and it has been recorded, but it is really a handful of cases, so it's considered relatively rare. Intrapartum transfer is possible, particularly if there's any stool contamination of the birth canal, because that is stool can be full of virus in an infected person. And finally, the postpartum transfer is while infected mothers can safely take care of healthy newborns, horizontal transmission cannot be ruled out if a mother has significant symptoms or doesn't use proper precautions. Once a baby and a mother go home, there is also risk from other family members or other caregivers. Whether or not SARS-CoV-2 can cross the placenta needs to be looked at in several different ways. Now, compared to viruses that spread easily from mother to fetus, like Zika, rubella, CMV, there are relatively few cases documented of SARS-CoV-2 vertical transmission. It is estimated that 1.9% of babies born to infected mothers will acquire the disease, will acquire infection, but the majority of this will be acquired postpartum. For a virus to reach the placenta, maternal viremia is necessary. However, viremia is rarely documented with SARS-CoV-2. Once that happens, the virus reaches the placenta. It needs both the ACE2 receptors and the serine protease TMPRSS2 for cleavage of the spike protein, as I mentioned before. And as it happens, ACE2 and TMPRSS2 don't co-localize in the placenta very frequently. So how does SARS-CoV-2 affect the placenta? This is a schema of a uteroplacental unit with cellular ACE2 receptor expression over gestation. You have a picture on the left side, a cartoon, which shows you the maternal side with the spiral vessels coming into the lakes, which are the maternal side of the placenta. And on the opposite side in yellow, you see the chorionic membrane, and you see a schematic of a single villus, the fetal artery and vein, and all of this is lined by a layer of trophoblasts and a layer of syncytial trophoblasts. So this is a normal, healthy fetal-maternal unit. And on the right side of the screen, you see several types of cells listed here, and I won't go into the details of them, but each of these is either a vascular cell or an inflammatory cell, and they may be fetal cells, or they may be maternal cells, or they may be on both. And you can see that early in pregnancy, there is more ACE expression on the maternal side. Whereas later on, in pregnancy, there is more expression on the fetal side. So there is a differential expression in early and late pregnancy, as well in chorioamnionitis, where you have certain cells overexpress ACE2. So that chorioamnionitis in and of itself is a risk for the mother to develop placental inflammation. Now there are 2 studies that have specifically looked at the placenta in babies with documented SARS-CoV-2 positivity. The first study was a study done on 11 patients and was published in 2020. There were 6 stillborns. There were 6 liveborns and 5 stillborns. And they looked at the histology. They looked for staining for spike protein. They looked for staining for inflammatory cells. They looked for staining for fibrin. And what they found was all of the brown that you see is spike protein around the villi, presumably in the syncytial trophoblasts. There you have lots of neutrophil invasion. You have monocytic invasion. And on the H&E stain, you see that nothing that looks like a normal placenta. The villi are pretty much obliterated. You see lots of fibrin deposition, perivillous fibrin deposition. You see syncytial trophoblasts that develop vacuolization. And you see massive invasion with histiocytes. So again, this is a second placenta, the same thing. The villi are surrounded by spike protein, and within the villi, instead of seeing normal cells, what you see is inflammation and perivascular inflammation as well. So then this particular author, David Schwartz, went ahead and did a second study where he got 68 cases rather than the first 11. And he documented the same findings all over again and added some new findings. And our pathologist, Dr. Saad, was part of this study. So some of our placentas are probably in this group of 68. So in this study, they looked at 68 placentas positive for SARS-CoV-2 after delivery. 64 were stillbirths here and 4 were neonatal deaths. Stillbirths were delivered at a mean age of 30 weeks. The range was 15 to 39. Live births were at a median age of 32 weeks. Range was 24 to 36. And the placental findings again were placentitis. And in this study, they actually quantified how much of the placental surface was involved. And a median involvement was 80% of the surface of each placenta. And a third of the placentas weighed less than 10th percentile when corrected for gestational age. So not only was there signs of inflammation, and in many instances, just obliteration of villus, normal villus vascularity, but this involved 80% of the surface of the placenta, and the size of the placentas was severely reduced in many cases. So they ended up saying that there was a triad of findings that will tell you whether or not you have SARS-CoV-2 placentitis. One is histiocytic intervillositis. So this is on the maternal side. You have lots of monocytes that invade the intervillous space, and instead of having normal blood from the spiral vessels coming in there, you've got that area crowded with monocytes, histiocytes, completely filling that space. Then there is perivillous fibrin deposition. So there's not any normal gas exchange between the villi and the maternal legs because there's all this fibrin deposition. And then you have trophoblast necrosis. This particularly affects the syncytial trophoblast. So the gas exchange unit, which is the villus surrounded by the maternal legs, is severely deranged. And as a consequence of that, you have babies being born stillborns because you have all of this inflammation and necrosis. So it's almost like having perinatal asphyxia. So the conclusion of the placenta studies was that SARS-CoV-2 placentitis can cause extensive placental damage as a result of destructive lesions, and that the damage can be further exacerbated by additional pathological abnormalities. Increased fibrin and massive perivillous fibrin deposition, chronic histiocytic intervillositis, and trophoblast necrosis results in sizable destruction of the villus capillary bed, accompanied by obstruction of the intervillous spaces, causing placental malperfusion and insufficiency that are incompatible with intrauterine survival. The fetal hypoxia that ensues can lead to a hypoxic ischemic fetal demise or neonatal death. So this is not the traditional hypoxic ischemic event that we see perinatally, but it's an intrauterine event, but nevertheless ends up in the death of the baby. So the conclusion on SARS-CoV-2 in pregnant women is that as per the most recent CDC statement, SARS-CoV-2 is likely no more infectious to pregnant women than it is to comparable non-pregnant people, but it does produce an increased risk for severe disease, and the complications of preterm birth, stillbirth, and other morbidities are there. Just very recently, there was a publication from the NICHD Maternal Fetal Medicine Network, which looked at 17 hospitals and showed that infection during pregnancy significantly increased the combined outcome of mortality and severe morbidities in women. It is in the most recent version of JAMA. So then we move to the neonate. When the pandemic first began, nobody had any idea as to how it was going to affect mothers or babies. At the present time, it is estimated that approximately 70% of pregnant women who are SARS-CoV-2 positive are asymptomatic and detected because of testing for contact exposure when admitted for delivery. The outcome of these babies is the following. Most neonates are born asymptomatic and stay well. However, the prematurity rate is reported to be threefold. The majority of preterm deliveries occur from maternal indications in symptomatic mothers. There is no reason to deliver a mother prematurely if everything is going reasonably well for her. However, in many instances, a mother is deteriorating and a decision is made to deliver the baby. Less than 2% of births from positive mothers are found to be SARS-CoV-2 positive when tested 24 to 48 hours after birth. And a small number of those infants actually develop symptoms. In terms of severity, many infections are relatively mild or asymptomatic. A handful are described as severe or life-threatening and include skin rashes, GI and feeding issues, lung disease disproportionate to prematurity or infection, and not responsive to exogenous surfactant, hypotension, and cardiac dysfunction. Rarely, multi-system inflammatory syndrome in children or MISC is described in the neonate. This is a CDC report where they looked at over 2,000 cases of individuals under the age of 21 who were reported from hospitals all over the country who fit the criteria for what can be called MISC. Fever and organ dysfunction in at least 2 organs and positivity for SARS-CoV-2. Of the 2,060 cases reported, 85 were infants. 83 tested positive and 2 had symptoms and were directly linked to an infected individual. The median age of this population was 7.7 months. The range was 14 days to 11.9 months. The symptoms were rash, mucocutaneous lesions, diarrhea, vomiting, injected conjunctiva, cough, shortness of breath, hypotension, shock, pneumonia, cardiac dysfunction, just to mention a few. Most of these children recovered in less than a week. 1 death was reported. So I would like to share with you a little bit about our experience in our NICU. So we have been collecting data from the time the pandemic was first declared, which was 22 months ago. And I'm giving you a month-by-month distribution of what we've seen. The first bar here is April of 2020, and the final bar here is January of 2022. And you can see that we've had 3 peaks. And these peaks coincide very well to when Alpha first came, which is the wild type,